I'm a surgical oncologist and I work in the breast and gynec oncology division of the Cancer Institute. I have a fairly long lecture, but I will cut it down in the interest of time. What I intend to present to you is the burden of cancer that we have and why so much of stress is required for screening, early detection and prevention. This is the institute from which I come, and we are celebrating the Diamond Jubilee year this year. We started from a small cottage hospital which had 12 beds, and today we have about 425 beds. Now this slide shows the global cancer incidence by gender. As you can see, the incidence of cancer in India is far less compared to the much more developed nations in the world and the world as a whole. In women, the crude incidence rate, that is the number of new cases of cancer per year per 1 lakh population, is about 93, and this is much more than the male. As you can compare with the less developed and more developed countries, our incidence is not so alarming, but we are seeing more cases because our population is also growing, as also our medical facilities for detection and treatment. Now, this slide shows the estimates of new cancer cases in India for the year 2012. It is estimated that we see about 10 lakh, just over 10 lakh patients in 2012. As you can see, it's almost 5.5 lakhs in women. The female cases are much more than the male cases. Now, what are the common cancers in women? My topic was on women's cancer. Now, in women in India, the common sites of cancer are breast, cervix, ovary, oral cancer, esophageal cancer, and large bowel cancer. Now, the common cancer pattern, as you can see, is different from that seen in more developed countries. And in India, we have a good regional variation. Like if you see in Delhi, Uttar Pradesh, the common cancers are gallbladder cancers. Between rural and urban India, in rural India, even today, the commonest cancer is cervical cancer. But in urban India, in all the metropolitan cities, breast cancer is the commonest cancer. Now, where do we get all this information from? All the information on cancer comes from population-based cancer registries that are located in all Indian states. In our own state, the MMTR, the Madras Metropolitan Tumor Registry, was set up at the Cancer Institute in 1982 by the ICMR. We have a rural registry at Dindigul in a place called Ambalikai, and today Coimbatore district also has a tumor registry, a population-based tumor registry. So all the information about incidence of cancer, prevalence of cancer comes from these population-based cancer registries. The other cancer registries are the hospital-based cancer registries, but information on incidence comes from this population-based cancer registries. Please remember that these population-based cancer registries do not cover the entire population of India. It is said that only about 20 to 25% or maximum 30% of the population are covered by these population-based registries. So a good majority is still not covered by the population incidence between male and female, between Dindigul, that is rural, and metropolitan Chennai. In Chennai, for male, lung is the commonest cancer, followed by stomach. It is the reverse. Stomach is the commonest cancer in rural India, rural Tamil Nadu, followed by oral and lung. In women, as I told you, breast is the commonest cancer. This number 34.8 is the crude incidence rate. 34 new cases of breast cancer in Tamil Nadu for 1 lakh population at Chennai. Cervical cancer is only 19.3, followed by ovary. So if you see, the top 3 cancers in women are breast and gynecological cancer. It is said that in all malignancies in women, 50% is formed by breast and gynecological cancers. Now, this I've already, okay. Now, incidence of breast cancer is steadily rising in the last 20-30 years. I have a couple of slides to show you the increase. Interestingly, cervical cancer is declining in India. Now, this is the slide that shows you the trend of cervical and breast cancers for the Madras Metropolitan Tumor Registry. The cervical cancer has declined from 1982. We have statistics. That's when the tumor registry started. Down, the incidence has come down from about 42 crude incidence rate to about 19. And breast cancer has steadily gone up. Now, the average annual decrease of cervical cancer is 3%, but proportionately the 3% rise in breast cancer. Now, what are the reasons for these changes? Changes in lifestyle. Most women now get married late. As a result of this, they have first childbirth after 30 years of age are more prone to get breast cancer, as are also nulliparous women. Now, nulliparous women who don't get married are nulliparous. Now, there is a trend amongst the metropolitan cities for women to get married and not have children. So, they are also at risk. And the other thing is the lesser parity. Earlier, we had larger families. Average family size was 2-3 children. Today, having one children, they probably have just one child. So, shrinking family size. This perhaps has contributed to the reduction in cervical cancers. We all know that in cervical cancer, the main risk factor, one of the risk factors is having multiple pregnancies, as also early age at start of sexual intercourse. So both these factors are inversely related. Endometrium and ovary. In the West, endometrial cancer is far higher than the incidence of cervical cancer. In India, the incidence of ovarian and endometrial cancer is growing very slowly but steadily. It's showing an upward trend. Today, ovarian cancer is the third commonest cancer amongst the urban Indian women. Now, what about this word called screening? We all hear screening. We screen for breast cancer. We screen for cervical cancer. Just to freshen up our knowledge, it's an application of a simple test in asymptomatic individuals to detect the presence of preclinical disease. So these are the requisites for any screening test, that it should have a long preclinical phase. It should be disease detected at this stage, should have an effective treatment that significantly alters the outcome. The test must be very simple and acceptable. Very often it should just be an office-based one-time visit. And the test should inherently have high sensitivity and specificity. And obviously the disease that we are screening for should have a high prevalence in our community. I think for all these, cervical cancer is possibly the cancer which is one of the very suitable cancers for screening. Now in the next part of my presentation, I'll briefly go on to breast cancer. Now breast cancer screening, how can we screen for breast cancer? One is doing a monthly breast self-examination for all women starting from the age of 20. The other thing that can be done is the annual clinical breast examination starting from 20. Now, who does the clinical breast examination is important. It's preferable to have a medical officer who's trained in it. It is not feasible for doctors to run screening programs and camps. So we need to train health personnel, nurses, community nurses should be trained in this, because as medical people, we know that we do not have time to even do all our therapeutic treatment. So we need more people from the community should be trained to do this annual clinical breast examination. What about the role of mammogram? It is recommended that mammogram be done annually after the age of 50, or at least biannually from the age of 40 years. In a large country like ours with limited resources, are we geared up in offering mammogram for every lady who wishes to have a screening? There is a big debate going on, and there are groups that believe that the time to screen with mammogram is still not come, because we do not have enough mammogram units to diagnose breast cancer. A lady who has a lump, for her, it is important to know whether it is malignancy. We want to know the contralateral breast. So she is priority more than an asymptomatic individual having a screening mammogram. So there are very strong groups, advocates of not having a mammogram. The group from Tata, particularly Tata Memorial, have very strong views saying that breast cancer in our part of the world, we should not stress too much on the screening mammogram simply because we don't have the facilities to accommodate a large population. And the other thing is, these in situ cancers, whatever you pick up on a mammogram, when you do a mammogram, you're looking for a non-palpable abnormality, an abnormality that is not picked up to a trained physician or clinician's hand. So what are you picking up? You're trying to pick up non-invasive, that is in situ cancers. Some of them believe that these in situ cancers may actually not grow in a big way. They may not even need to be treated at all, like prostate cancer. Prostate cancer is another big query coming on the benefit of prostate cancer, because they feel that screening prostate cancer is not going to be useful because possibly the patient will live with the cancer and die of other causes. And you'll all recall that in autopsy series, the commonest cancer diagnosis, prostate cancer, people lived with the cancer, but they died of other reasons. What happens if you screen the community? In communities with invited community screening programs for breast cancer, the mortality definitely reduced. The mortality for breast cancer decreased by about 25 to 30%. Now this, I think, in the West, in UK, US, where they have strong screening programs, they have demonstrated reduction in mortality. What about an individual patient who has a regular annual mammographic screening? The mortality for that patient may be reduced by a slightly higher proportion. Now, breast self-examination, how useful it is. We tell patients when they come to us, we give them pamphlets, we teach them what to do. They say that the sensitivity of this test is quite low, but definitely it is good to make the woman aware of her breasts. So at least such a stimulated woman, a lady, would probably present to us early. She wouldn't ignore a nipple discharge. She wouldn't ignore a change in her breast. So it is worthwhile to teach them breast examination and make them more breast aware. They at least look at their breast with the thing that, let me see it every month, let me report if there is a problem. The clinical breast I've already told you. Now, I'm not going into the treatment of breast cancer. Now, one of the ideas at a stage where it can be cured better. Now, this is the slide that shows you the stage distribution of breast cancer patients treated at the Cancer Institute. You will see that bulk of the patients come in stage 3. About 50% of our patients present in stage 3, which is locally advanced breast cancer. Locally advanced breast cancer means any breast cancer that is more than 5 centimeter in size or has matted axillary nodes. So any cancer that is above this stage, 5 centimeter and a matted axillary node, comes into the locally advanced breast cancer group. Now, locally advanced breast cancer group requires multimodal treatment. That means they need surgery, which is mastectomy, they need chemotherapy, and they also need radiation. So if you get a cancer in stage 3, you need to incorporate all these 3 modalities for that patient. Supposing the lady with awareness and screening, she gets a cancer in stage 1 or stage 2. Stage 1 will be a cancer which is less than 2 centimeter that has confined to the breast. Today, only 2% of our patients present in that stage. If we step up our awareness, people are more aware, and we do some screening programs, we probably will get patients more in stage 1 or in stage 0, that is the DCIS group. And obviously, if you treat patients in early stage, your survivals are going to be far higher than treating patients in stage 3. In stage 3, 50% of our patients, they expected to survive, about 58% are expected to survive for 5 years. As you can see, earlier the stage, better the survival. So the crux of all our awareness and early detection, we should remember these slides, these survival curves. Earlier we detect cancer, better for the patient, lesser treatment, morbidity, lesser mutilating treatment, more conservative treatments can be done. A very ideal cancer for screening because it has a very long natural history, starting from a pre-invasive phase, CIN1 through CIN2, 3, and then to an invasive cancers. Now, of late, I think there has been some change in terminology where they've grouped CIN2 and CIN3 together as CIN2 plus. But remember that all CINs do not progress to invasive cancer. majority of low-grade CINs regress with time. And for a low-grade CIN to progress to cancer, it's going to take about 10 to 15 years. So you have a big window of opportunity to detect them in this pre-invasive stage and offer treatment. Now, cervical cancer, although the incidence is coming down without any major screening program in India, why has it come down? Some of the factors attributed are low parity, having delayed, delayed age at marriage. Another factor is, we all know that 99% cervical cancers are associated with HPV. Now, HPV, although we have not done any HPV vaccination, why? It is associated with better sexual hygiene. We all have, much of the population has access to better water. So there is more cleanliness, there is more better genital hygiene. So these are some of the factors that are explained for the reduction in cervical cancer incidence without having any screening program whatsoever that are available for screening cervical cancer. That can be a separate debate and lecture by itself. Well, the commonest test that we perform, the first test that we learnt for screening is the pap smear. It's ideal to start a pap smear from the age of onset of sexual activity. We all know that it's a very simple test to perform, but it has to be carefully performed. You need good expertise, practice to take the right smear at the right time. There are some precautions that you need to do. I don't know whether all of us are practice all this. It should be timed at the right time. The patient should avoid vaginal douches. There should have been no intercourse 48 hours prior. And a sample is taken with both a cytobrush and an IO spatula. And if we have access to liquid-based cytology, that is superior. But even if we don't have LBC, the standard smears that we use are better. Now, what can you detect in a pap smear? In a pap smear, you can detect normal cells, you can see dysplastic cells, you can see frankly malignant cells. Based with the pap smear, then you will make a diagnosis of, if there is dysplasia, then you will ask the patient to have a colposcopy or a colposcopy directed biopsy. And then if there are pre-invasive cases like SIN1 or SIN2, SIN1 mild dysplasia often doesn't require any treatment. Moderate and severe dysplasia definitely requires treatment because a third of them can progress to invasive cancer. Now, the other modalities of screening for cervical cancer is the VIA, visual inspection with acetic acid. There are a lot of advocates for this screening method. They say that it can be easily done as a single test. You see, you find out a problem, you find acetowhite, then you can immediately treat the cancer. The disadvantage with pap smear is that you do a pap smear today, the patient has to come back to see her report because it takes the cytologist has to interpret the slides. So they say that the VIA is a better test. In a single visit, patient does a VIA, there is abnormality, then the treatment is done. Well, it needs a good trained setup to perform the VIA, catch the right VIA positives and then treat them. By treatment, what is the treatment that you can give? If you have VIA positive, then many people recommend doing a leap excision. Now, it's not that all VIA positives are cancers. I have a slide to show you if you can see the lacy pattern there. These are VIA positive ones. I think I've lost that slide. Now, if you do a screening of hundreds screening for cervical cancer, it is estimated that about 8 to 15% will have VIA positive. And of these positive VIA, only a quarter of them are likely to harbor SIN2 or SIN3. So the numbers are actually less. So if you see and treat all the VIA positives, you're going to be high-grade cervical intraepithelial neoplasia. So there is a flip side to using VIA, but there has been a couple of trials that have been done where they have used VIA. The group from IARC, from Shankar Narayan's group, has demonstrated that VIA immediate see and treat has shown benefit, but it has to be taken with a critical thing. The other method besides VIA pap smear is whether I don't think I have the other slides. The use of HPV testing, whether HPV testing can be a screening method. As I already said, 95 to 99% of cervical cancers are associated with HPV testing. Now, whether we can use HPV testing as a screening test. They did a trial in Osmanabad in Maharashtra. They compared 3 groups. One is pap smear, one is VIA, and one is HPV testing. And the group from IR, Dr. Shankar Narayan's group, concluded that if you have single-time HPV testing, it is more cost-effective because the reliability of a HPV testing kit, the results are much better. But that was the only group that showed the expense is much, much more than a pap smear test. And for today, our population, I think it's going to take a long time. It can be done in like an individual interest, but I don't think it can be done as a screening. Now, what about the role of HPV vaccination in cervical cancer prevention? Now, I think it is included in the immunization protocol to have HPV vaccination for girls, and sometimes they also push it for the boys, I think. Well, it's difficult to say that if you give HPV vaccination, you prevented cervical cancer. They say you give the HPV vaccine in the adolescent age group before the onset of sexual intercourse. Is it going to cut down all the cervical cancers 20 years from now? No. All these women or all these girls who have HPV vaccination also must have annual screening. They actually go through the same screening like other women. It's not that once you give them a vaccination, you say they're never going to get cervical cancer. The reason why some people say HPV vaccination is not very useful is most women actually have HPV infection some point in their reproductive life. And for most women, the HPV infection clears on its own. So what is the funda in having this HPV vaccination? So that's also a point of debate because much of these trials which did the HPV vaccination, the number of trials, the endpoint was not cervical cancer. The endpoint was only CIN. So there's still a lot of debate on whether it should be pushed in a big way. Certainly for a country like ours, I'm really personally not sure it should be pushed too much. I think more emphasis should be on health education, making the lady more aware not to neglect even small symptoms and maybe have an annual test. Now, this is the slide that shows you the stage distribution of cervical cancer. As you can see, you have only 11% of patients presenting in stage 1 and bulk of them present in stage 2. Of stage 2, 2B is more common than 2A. 60% of cancers present in stage 2, a quarter of them present in stage 3. So if you combine stage 2 and stage 3, it's about 80 to 85% of our patients present in stages 2 and 3. And as you know, like in breast cancer, although the fall is not so sharp, if you have an early cervical cancer, your chances of living is much higher than if you have a stage 3 cancer. Now, the last part of my thing is on cancer ovary because that's the third commonest cancer. We all know that of the gynecological cancers, it is considered the most lethal of them. The incidence is slightly on the rise. Now, is screening successful for ovarian cancer? Now, in ovarian cancer screening, we all know about transvaginal ultrasound. There's been a lot of studies on using transvaginal, transabdominal ultrasound, combining it with CA-125. But all I can say is, as far as ovarian cancer is concerned, there is benefit only in high-risk individuals. Now, high-risk individuals are those who are BRCA positive, who have a strong family history of breast, ovarian cancer, and maybe survivors of breast cancers because they are women who will actually benefit from the screening. It is not beneficial to be done for normal risk individuals and for the population. Right, this is the slide where you do HPV testing done along with the pap smear, as I mentioned. Now, in conclusion, I just like to conclude that in India today, breast cancer incidence is steadily rising by about 3% per year. Cervical cancer is decreasing. Now, the early detection holds the key to better survival, and all of us should join hands in our own small way, like has been done here. I shouldn't call it small. In our own way, gather hands, increase awareness about cancer, spread it to neighborhoods, to bigger localities, to colleges, to educational institutions, and preventive strategies are to be incorporated to increase more awareness to get better results. Thank you, and thank you for the opportunity to have come.